The United States needs a health care policy. We do not have one. What we have are a number of different health care financing policies, but we do not have an overarching health policy in this country. In the 60s, we clearly introduced Medicare and Medicaid and concepts like community health centers for the poor and vulnerable populations. We recognize and hear every day that our budget deficit is unsustainable. The increase in Medicare budget is not sustainable. We're spending more than 17% of the gross domestic product on healthcare in the United States right now. Unsustainable. Clearly, Medicaid for the states are felt to be unsustainable. And the challenge of employers needing to cost shift because of premium expenses, either to their employees or to consumers, again, everyone acknowledges unsustainable. You look at the revenue stream that comes into the federal government from taxes, et cetera, all revenue sources. You can see that, again, the expenditures on Social Security discretionary programs is pretty constant. But again, you look at that trend on health care and interest on the debt, and that's where our challenges lie. Those are the areas that we have to get under control in order to, again, get to some sense of balance and stability. So, when I said we don't have a health care policy, let me share with you countries that do have health care policies. The Bismarck model. Health care providers and payers are private entities. Let's look at the Beveridge model. Here, health care is provided and financed by the government through tax payments. There are no medical bills. Then we have, if you go to Canada, the national health insurance model in Saskatchewan. Again, has elements of both the Bismarck and the Beveridge model. Payer is government-run insurance program that every citizen pays into, and the insurance plan collects monthly premiums and pays bills. And then there's what we refer to as the pure out-of-pocket models. And the basic rule is quite simple. The rich get medical care, and the poor stay sick or die. I mean, that's fundamentally a lot of the worldwide models. So the world's poorest countries have the highest percentage of out-of-pocket payments for health care. So again, you can see all the way from Mexico to Myanmar the kind of outcome, and in the United States we would target that level at about 15%. And again, those are the folks without coverage today. The question is, do you leave a large segment of the U.S. population without coverage? That is a pivotal issue. You know, how can the uninsured or underinsured be insured? How should we have the healthy and young subsidize the older and less healthy? And how should personal health and accountability be pursued? Now, from 2014 to 2016, this is going to get very, very intriguing again. The notion of an individual mandate, and because, again, our youth are invincible, they feel that why should they buy health care coverage when they really don't need it? I mean, that's really fundamentally one of the challenges that we face. As a matter of fact, there's an argument to say you'd be crazy to buy health insurance until you've identified yourself with a chronic disease or condition. So why buy health care if you all of a sudden are a cancer victim? Go get it then because you can't be denied. So again, that's kind of the perverse side of how humans will behave given certain incentives.
How do you propose, the graph you showed was that the cost of health care is about the same with Europe up until age 57, then it skyrockets here. How do you propose under the Obamacare Act and so forth to deal with that cost? If the point is to drive costs down, will that cost be dealt with other than having patients wait? Because in Canada right now, the way they keep the costs down, they have a specific budget for their monthly budget that people can go to the so-called operating room, and if they exceed that budget, those people have to wait until the next month before they can get service.
Correct.
So how do you propose to get away from the waiting system?
I don't know that you do. And I'll think it's even more challenging than the point that you're making. Because I've got such faith in our elected system and the power of the senior vote, here's what I predict is going to happen. Is that issue is not really going to be dealt with in a public policy kind of conversation that we're trying to have right here, because it's all about choices. At the end of the day, my prediction is that as healthcare systems and providers, whether we use an ACO mechanism or some variation like that, we're going to get a fixed amount of money to take care of a population. That's what's going to happen. And that prioritization of who gets what, when, and how much is going to fall upon healthcare providers, because it's a non-electable issue for our officials. It's a non-electable issue. The biggest travesty we ever had in terms of trying to come close to dealing with this, and we've done this a number of times, is when you start articulating things as death panels and death squads. That is really an abhorrent abuse of what should be good conversation. Because again, I can assure you, as I talk with my physicians, they get frustrated when they know that the clinical outcome is going to be no different. But because of lack of clear direction regarding what are your advanced directives, should we do palliative care instead of another heart procedure, etc. Those are the fundamental core issues. So you can talk about everything else and be frustrated by everything else that I have shown you, but where the metrics show that we have to go is to deal with the amount of care that we're investing at the end of life. That's the core issue. And how are we going to do that, or are we going to stay a patchwork, which we have been? So that's why I'm saying these are huge policy issues that need to be determined.